Okay, I think we can begin now. Good afternoon, everybody, and thank you so much for joining us today for today's webinar, the Patient-Centered Medical Home and Value-Based Survival Skills. My name is Elise Friedman, and I'm your host for today. And today we'll be talking about the value of the patient-centered medical home as you face increasing pressures to meet specific complex quality measures and the associated mounting reporting requirements. The NCQA recognized PCMH has proven to be one of the most effective platforms in positioning providers for success in value-based transformation. NextGen has a team of professional services consultants, and they consist of a number of NCQA PCMH certified content experts. And today, presenting today's webinar will be Dr. David Mattarella. He has significant expertise in practice transformation through patient-centered medical home models. He's a clinician with a pediatric residency from Medical College of Ohio, as well as the pediatric critical care at Baylor College of Medicine in Houston. He's one of NextGen's NCQA PCMH certified content experts, and he's been a physician consultant with NextGen since 2011. He's been helping NextGen clients optimize their technology platforms to provide high-value, cost-effective care to their patients. Today, we're also joined by Dr. Amanda Heidemann, and she is the Senior Director of Clinical Transformation here at NextGen within the Professional Services team, as well as Andrew Glatfelder, who is our Senior Director as well, a Senior Regulatory Compliance Consultant, and he is also on our Physician Consulting team. He assists our clients with government reporting such as PQRS, MU, ACO, et cetera. Anyway, I thank you so much for joining us today, and I'm going to turn this over to Dr. Mattarella. Again, we are recording the webinar. We will distribute that recording to you via email within a few days. And please save your questions for the chat panel or the Q&A, and we will take those questions after the webinar is done. Thank you so much.
All right. Hello, everybody. Yes, thank you, Elise, for that introduction. And thank you for joining me, everybody. I'm coming to you guys from Richmond, Virginia, and it's a beautiful day outside. Our leaves are turning from green to orange. So it's gorgeous in Virginia, lots of trees here. Hopefully, you are also having a gorgeous day. And thank you, for joining me as I learn. I'm glad that you're learning with me. To start with, the learning objectives for today are, three simple questions, and I'm going to keep it basic. What is practice transformation? How do I get rewarded for practice transformation? And how do I transform my practice? And so these are the three questions that we are going to answer as we move through this presentation. First and foremost, I'd like to ask the question to begin with, patient-centered, what is that? And then what is population-focused? What are those two things? Well, when you're talking about patient-centered, let's say, for example, a diabetic patient, maybe the provider is seeing this patient in the clinic during the encounter, and there's certain pieces of information you want available, the provider needs available, the practice team needs available. You want to know specific things like, are the labs are there for me to review? Am I aware of all the chronic conditions this patient has? What are the support structures this patient has at home? What are the barriers is this patient having? What demographic does this belong to? Are we capturing this information? So, that patient-centered information we need. Simultaneously, we also need to learn about our population. Let's say for this diabetic patient who belongs in your practice's diabetic population. And you're wondering at the same time, well, how am I managing my diabetes population? Are they losing weight? Are they compliant with their medications? How are the HbA1cs doing? Are they overall going up, going down? Am I getting data from my systems that I have to kind of support this population type of care and this patient-centered type of care? Because through this, by using these kinds of concepts, we want to improve the health of our patients. We desire to keep our patients, those that are healthy, from not getting sick or getting chronic disease. However, despite our true grit and our effort, there's many studies out there that are showing that our patients are getting more chronic disease as time moves along, and they're not necessarily getting better. And so we need to figure out what is happening here. How come, even though we're putting so much effort into taking care of our patients, that we're not seeing a return on that investment, you know? So is it because we have some type of blinders on? Is it that we have information available to us, but it is not accessible to us, or it is not there at the right time, maybe not at the right place, maybe it's not going to the right person, maybe it's not coming to us in the right way. And, you know, because of that blinder, that information that we have in our systems, in our different technologies, whatever modules we have, we may not know our populations very well. We may be slightly blinded, not only about our populations of hypertension and diabetes, but also we may not know our specific individual patient very well. You know, on this slide, that's at point A, just trying to get to point B. In point B, you know, you are now, information is available, it is coming to you at the right time, at the right place, to the right person in the right format, and you're able to understand the population better. The blinders are removed, and you're actually able to identify patients that are sicker, that need specific care. And that defines a little bit of what practice transformation is. You know, removing those data blinders and becoming a data-driven practice. And as we move forward in our care, this data is going to become very important, and we have to learn how to use it. But is just using data in the proper way and having it available to us at the right places, is that what practice transformation is? Are there more elements to practice transformation? And I would like to go ahead and talk about those other elements that are involved. And those would be, of course, yeah, we talked about patient-centered earlier and using data to understand our patients, the clinical data behind our patients. We also looked at population-focused and looking at our EHRs, our technologies to create reports of our populations, of diabetes populations, see how we're managing them there. But at the same time, we can also use our technologies and our data to be more coordinated because we have complex disease, complex patients, and they go to various places to get care. They go to labs and diagnostics and community resources. And that information may not be arriving to us in a proper way or in a timely fashion. And what is it that we need to do to improve that process of coordination, you know? That is, again, a piece of practice transformation. The other part of practice transformation is improving access. You know as well as I, in an economy such as today, many of our patients have multiple jobs, and they do different shifts. Some have morning shifts, some have an evening shift, some even have a night shift. And not only that, they also have different ways to communicate. They have cell phones, they have patient portals, they have emails, they have telephones. You know, we need to be able to provide health information to our patients when they need it. Also, we need to be able to provide our services, our care services, to them when they need it on their schedules, you know. So that is improving access, and that becomes a part of practice transformation. The other piece of it is team-oriented. You know, that is critical in that our patients, again, are very complex, and there's lots of things going on. There's many things to follow up on. They're being hospitalized. They're going to the ERs, and me as an individual doctor cannot handle the complexity by myself. And the question is, you know, am I using my medical assistants? Am I using my nurses? Am I using my practice front desk staff, my practice administrator at the highest level possible so they can collaborate with me and share this responsibility of taking care of my patients? You know, that is, again, a part of practice transformation. Now, also, we as providers, we as practices always want to improve in the way we do things, you know, and we want to measure our performance and then look at where we are and then improve. And that is a huge piece of practice transformation. So with these 6 elements, you know, you're not going to arrive at practice transformation overnight. It's not going to happen in 24 hours or just by being recognized as a patient-centered medical home. It is a process, it is a continuum, and it may be never-ending, and you become a learning system as you deliver care. So that is what we're talking about as practice transformation. Let's dive into the data just a little bit and see what's going on with our patients at the current type of care that we give, this type of service volume mentality. We see a lot of patients and see where we are, right? When you look at it, whether if the reason is environmental, economic, genetic, or behavioral, this is a glimpse of what we face today. 117 million people have chronic health conditions in 2012. It's probably the same now. And the next point, 7 out of 10 people, the deaths are due to chronic diseases. That's in 2010. So our current system of care and the way it's working, it's not really working for us well. It's not working for our providers or practices, neither is it working for our patients. If you look at some more numbers, 33% of our adult population is obese, right? And 47% have major risk factors toward heart disease, stroke, high blood pressure, LDL is elevated, current smokers, high sodium diets, and the list goes on, right? So we as providers really, the reason why we got into medicine, whether it's a medical assistant, whether it's a nurse practitioner, a physical assistant, or a provider, you want to get your patients healthier. But for some reason or other, we're not able to turn it around, even though we're putting a lot of work into this, So, we want our patients to get their colonoscopies in time. We want our patients to get their mammograms in time, the pneumococcal vaccine, or whatever preventive measures that need to be done. We want these things to be done, but even, again, a lot of studies show that we're not there yet. And we need to figure out ways to bring our patients in so that they can get these preventive care services. We want to identify patients, those that are specifically sick. I mean, we have a general population, but within that population, you want to identify patients that are troublesome, that are high utilizers of the health system. Maybe they are on costly medications. Maybe they have, major depressive disorder, behavioral health conditions. Maybe they have chronic complicated disease, not, diabetes uncomplicated. Diabetes complicated, hypertension complicated, and whatever else. Or maybe they have poor social determinants of health. Maybe they're unemployed, widowed, divorced, no education. Maybe they don't have a home. We want to identify these people and give them improved care, closer care than the general population, right? So, the question is, have we arrived at a time where we can actually do this kind of stuff? But at the same time, it makes sustainable economic sense for us, that we are actually going to be rewarded for the value that we're going to be providing. Not the volume of patients we're seeing and providing service, but the value that we're going to provide, and at the same time, get rewarded for it fairly. And that's where we are today, Let's look at NCQA 2014 PCMH. It is a highly recognized program throughout the country, and as Elise mentioned earlier, and these are some of the things that it can do. I'm just going to go over some standards in PCMH, Patient-Centered Medical Home, NCQA 2014, just to kind of highlight some stuff, For one example, we want to know our patients better. We want to have the clinical data of patients available to us. And we want to have processes in our practice in place, workflows in place, where we are capturing advanced directives consistently, not haphazardly now and then, right? We also want to consistently know the breakdown of our patient population. What languages do they speak? What gender are they? What ethnicity are they? Are they unemployed? Are they employed? What kind of jobs do they have? When you look at health maintenance, when is their next colorectal screening due or breast cancer screening due, right? Also, what kind of supporting services do I have for my different diverse population? How many of my patients smoke? How many of my patients have bad habits with alcohol? these are things that we should consistently capturing and knowing our patients as we take care of them, and that those elements are available, but are we capturing the data? Do we have the workflows in place? Are our medical assistants and nurses, have ownership of this, and are they doing it? The standard that improves this in PCMH is population health management. It provides opportunities to learn our patients and for the identification of patients who need services and remind them of the needed care so you can bring them in and provide those preventive care services. That's population health management. That is a standard in NCQA PCMH. And let's look at another one. We also not only want to know the clinical data and and be aware of what we're collecting on these patients, we want to use that data and we want to be able to, by using that data, we want to be able to identify patients who are high utilizers, who are more complex or have significant chronic disease or have poor social determinants of health. What is that standard called in PCMH? That is called care management and support. That is where this standard provides the opportunities for the identification of patients who have complex issues and places focused attention on them. So that, you want to be able to identify your patients here who are sicker, who are more complex. And we know that we cannot do it alone. There are complex patients out there, and there's many of them, and a provider by themselves are not able to do it. We need to equip our medical assistants, we need to equip our nurses to help do this, and we need to train them to bring them up to a level where they can collaborate with us and share in the responsibility. And that standard in PCMH is called team-based care, which provides opportunities for clinically meaningful collaboration between provider and support staff focused on improving the health of our patients and our patient populations. The next standard is we want our labs available to us. We want our imaging. It's very frequent that when we're seeing patients, that those labs are not available, those referral reports are not available, those imaging results are not available, and I'm not able to make a good clinical decision on my patient because that information is unavailable, and it creates inefficiencies within the practice and havoc. But there's a standard in PCMA that's called care coordination and care transition. This is where we are provided with the opportunity for improved communication between specialists, hospitals, emergency rooms, labs, diagnostic centers, and other community resources, right? And convenience. We talked about this before, that our patients, multiple jobs, various ways to communicate, and we need to be more accessible, not only with our patient information for them, but also physically being available to them when they need to talk to us and when they need to see us, right? So that is called patient-centered access, another standard in PCMH. And we want to continually improve in the way we do things. We want to make sure that, let's say if I have a colonoscopy campaign, is it working? Let's say if I have extended hours at the clinic, do my patients, are they using them? Are they aware that I have extended hours? Maybe I have a diabetes program, and is that diabetes program really working, right? So you want to measure these programs that you have and do quality improvement projects on them so you can continue to improve over and over and over again. And last but not least, and very important, is we're going through this practice transformation, and we're providing this great value to our patients. We're using data. We have all of these concepts. However, we also need to get reimbursed for this. We need to get rewarded fairly for this. And that's where the Medicare Access and the Child Health Insurance Program Reauthorization Act of 2015 comes into play. For short, it's called MACRA. And MACRA gives way to a program called the Quality Payment Program. And we're also going to discuss that just to kind of at a high level of what that is. So we talked about the elements in PCMH, NCQA PCMH, right? I just want you to look at the structure of it a little bit. When you look at it, outside there are 6 standards, right? There's 6 total standards, and we've talked about them. And then under each standard, there may be multiple elements, right? And under each element, there may be multiple factors. And that's how the whole thing is structured: standards, elements, and factors. Now, we've discussed these already, but PCMH1, patient-centered access, PCMH2, team-based care, PCMH3, population health management, PCMH4, care management and support, PCMH5, care coordination and care transition, PCMH6, performance measurement and quality improvement. All of the landmarks, all of the elements to create practice transformation in your practice. And just to show you how it looks, an example of a document that comes from NCQA, I just wanted you to look at that. I know that some people are beginning in the PCMH process and some people are very mature in it. I'm just covering all ground here. So when we're looking at PCMH, here we're looking at standard 3, which is population health management, which has element D. So there's element A, element B, element C. We're just looking at element D, which has 5 factors in it. Basically, that's it. Just note that it says the must-pass element. That means that you have to get a 50% score on this element, but each standard has 1 must-pass element. So there are 6 must-pass elements, and you have to get a 50% score to be able to pass this element and to be able to get recognized on any level, right? Level 1, level 2, or level 3. Right, so that's basically an introduction at a high level of the PCMH standard, element, and factor. So now let's look at payments. Let's look at MACRA. Let's look at the quality payment program that has just come out. The final rule just came out about a week ago, so everybody's busy going through this 2,400-page document. Let's get at a high level in terms of how it relates to a patient-centered medical home. That's what we're going to focus on. So historically, I just want to go into, what was before. How did we get paid before under Medicare? Right? There were fee-for-service payments, and they were based on volume. And then we saw the data that we kind of went through to show that that was ineffective. Our patients were not getting better, right? So there had to be a change. And so the change is through MACRA, right? And under the fee-for-service, historically, there was a formula called the Sustainable Growth Rates Formula that was established in 1997 that actually dictated the reimbursements, the formula dictated the reimbursements that our physicians got under Medicare, right? And that has been repealed now. And now we are now moving into this quote-unquote MACRA, which gives way to quality payment program. Let's talk about MACRA and the quality payment program, right? So this is the quality payment program, or MACRA. The statute is MACRA, and under MACRA is the quality payment program. Now, there are 2 branches to it. One is called the Merit-Based Incentive Program. Some people call it, in short, MIPS. And note that in MIPS, we were previously, historically, been doing meaningful use. We were doing digital quality reporting system and value-based modifiers. And there were individual programs that we were reporting for payment adjustments, incentives, and things like that. Now, though, all those 3 entities are now in MACRA. They're not 3 separate programs. They're all consolidated into one program, which is called Merit-Based Incentive Program. Now, when you look at the Merit-Based Incentive Program, there are 4 categories, right? The first category is quality. The second category is resource use. The third category, and this is a new category, and I'll explain why I'm saying it's a new category, it's called clinical practice improvement activity. And then the other category is advancing care information, right? So when you talk about quality, all those measures that were in PQRS fall into the quality category. When you talk about resource use, all those elements that were in value-based modifier fall into the resource use category. And when you talk about meaningful use and the EHR incentive program, those measures, they fall into they align or fall into the advancing care information category. Now, the clinical practice improvement category is an additional item that CMS has included under the merit-based incentive program. So that's one branch, and it's predicted that when this program starts in 2017, that most providers most of them will be in this branch right here under the merit-based incentive program. However, some providers will be in these advanced alternative payment models. And the common denominators for these advanced alternative payment models is the following. They are all going to get a 5% annual bonus fee-for-service payment. And the other common denominator is they're all going to use electronic health records, certified, and they're also going to use some parts of quality, And then they're also, the interesting thing here is that they also will be involved in upside and downside financial risk sharing, right? These are accountable care organizations, bundled payments, shared saving programs, these kinds of things. Really, large institutions, large ACOs or ACOs that have matured are able to take and go through this, downside financial risk. Maybe smaller providers may not be able to handle the downside financial risk. But we want smaller groups and smaller practices involved in advanced alternative payment models, and that will be in terms of without risk, that will be medical home models for the smaller providers, less than 50 providers, in which there's no risk involved. So those are the two branches of the quality payment program. One is the merit-based incentive program, and the other one is the advanced alternative payment models, right? Let's continue to talk a little bit more about this. Now, over time, as these advanced alternative payment models expand and get more people from the MIPS side, MIPS eligible clinicians, will be moving over and also start participating in as qualified participants under the advanced alternative payment models. All right. Now, we talked about MIPS, and I said that there were 4 performance categories, right? So when you're participating in MIPS, there's going to be a score, and that score is called MIPS Composite Performance Score, and that score goes from 0 to 100, right? And the way you perform in quality, in the first year anyway, 2017 transition year, so that's the first year, the way you perform in quality and how you perform in the clinical practice improvement activity and the advanced care information contributes to that MIPS Composite Performance Score. And these categories are weighted. So the quality is weighted at 60%. The clinical practice improvement activity is weighted at 15%, and the advanced care information is weighted at 25%. Now, look at resource use. For the year 2017, CMS has decided that there's no weight for resource use. Maybe in 2018, and that remains to be more defined, but for right now, 0% for 2017, right? So all of these added up, depending on how you perform, you may fall anywhere between 0 to 100 on your MIPS Composite Performance Score, and how you perform on that MIPS Composite Performance Score dictates if you get a positive payment adjustment or a negative payment adjustment. Now you're asking, well, where does PCMH fall into all of this? Where do we fit if you do PCMH? Or if you're already recognized, how do I fit into this, right? So the place you fit in is right here in the clinical practice improvement activity. If you are a practice that is PCMH recognized, you get 40 points. Now, clinical practice improvement activity for 2017, the transitional year, is capped at 40 points. So you get the full gamut of points for being a PCMH recognized. And so you get 15% towards your MIPS composite score. And that's where PCMH, you can be rewarded because you're creating a practice transformation and you're providing higher value, and that's where it helps you as far as payments are concerned for the year of 2017 and so on and so forth. Now, you may be wondering now, there are many PCMH programs out there, and you may be wondering, well, what PCMH programs qualify? So, well, CMS says, well, it has to be a national program or a regional or state program or a private payer, as long as they certified 500 or more practices of patient-centered medical home accreditation. So that's kind of what they're looking for, and they actually gave some examples of what those are already. And so those examples are provided on the statute. Is the first one, the first example is the Accreditation Association of Ambulatory Healthcare. That's the PCMH program. Now, the very popular one, the National Committee for Quality Assurance, NCQA PCMH recognition. And the next one, the Joint Commission designation is another one. And this one, Utilization Review Accreditation Commission, URAC. And those, that's for primary care. And what about subspecialties and specialties? Can they qualify? Yes, they can. And the one in the statute that's been stated is the patient-centered specialty recognition under the NCQA will also be is acceptable. And and your vendors, your EHR vendors, should be helping you in assisting you in getting recognized for one of these types of programs. All right. So now we're going to talk about PCMH preparedness. The first part of the talk, we talked about what is practice transformation, and we defined those 6 elements, and we talked about PCMH. And then we talked about, well, if I'm providing this value and I'm creating this practice transformation, how am I going to get rewarded for it? And we talked about the quality payment program, and we talked about the MIPS and the composite score and the clinical practice improvement activity where PCMH fits, right? Now you want to know, well, how do I do PCMH? How do I create practice transformation within my practice? And I'm just going to, as I go through this, I'm just going to bring out some of my own experiences as I work with clients, throughout the country regarding PCMH. First and foremost, it's a partnership between the PCMH program, the EHR vendor, and of course the practice, and it is a deep partnership. The PCMH program allows for application and assessment, right? And you need to stay in close connection with them, understanding their rules. Now, the EHR vendor should also have a good relationship with that PCMH program in that, for example, with NCQA, EHR vendor can become pre-validated, right? So, and I will define to you what pre-validation is later on in this talk. Also, the EHR vendor can grow PCMH subject matter experts. They're called PCMH Certified Content Experts, PCMH CCEs, and they can go through NCQA and develop these kind of specialists within their EHR services as a vendor, right? And then provide those tools to our practice that is transforming, right? So it's a critical relationship between the EHR vendor and the practice. And so this whole triad is important for you to succeed in your recognition and, more importantly, to create that practice transformation, which occurs over time. It does not happen overnight. So when you look at PCMH and different programs, they basically have a laundry list, not a laundry list, but a direction on how you do things. And this is an example of a map where, there are free services for onboarding available, seminars available that you can educate yourself about PCMH at the individual programs. This is an example from NCQA where they actually give you a step-by-step process on how you learn it, how you earn it, and how you keep it, right? And you can actually click in and understand what that process is. And that's on the program side, the PCMH program side. How about at the practice side? What is important? If you're not, one of the most important things, probably the most important thing on this talk today is culture. We cannot have this practice transformation without having a a founding culture that is able to take the change that is about to happen, right? And it needs to be an excited and growing culture and made up of a team that can foster that culture. So you're going to have to develop a core team that is really passionate about this movement forward, right? You are going to need a provider lead in that team. That's going to be very important. Now, that provider is very busy with clinical practice, especially if it's a smaller practice, but maybe larger practices and larger systems can actually have a provider as a full-time person. However, no matter where you are in that spectrum, it's good to have a clinical lead central to your core team to kind of strategize workflows, strategize processes, what to do performance measurement on, what to do quality improvement on, right? You also need a quality lead, meaning that sometimes the provider is busy and may not be, you need a subject matter expert of the quality payment program, of PCMH, or whatever else program that you're involved in regards to quality. That's going to be a critical part of your team. A patient is also important, and I've seen in several places where they have an advisory panel and patients are involved in some meetings, not all, right? And leading MA, now this is an MA who is energetic, who is smart, who is looking forward to this change. Those are the people that you want, not only as an MA medical assistant, you'd want a nurse, you'd want a practice administrator, and you need leadership, especially in large institutions. Without leadership structure, your culture will fail and your progress forward will be difficult, right? You also want care managers in this team and billing people in this team. So I would invest a lot of time, a good amount of time, really picking the right people to be a part of the team, because it's going to look at internal clinic processes, you're going to look at internal workflows, you're going to be standardizing workflows, you're going to be creating reports, you're going to be doing small rapid cycle improvement projects within the practice. So all of this becomes it's not sustainable without a good core team. Also, the other important thing I think that needs to come to the highlights is gap analysis that the practice needs to do. Not only do we need to have a strong core team, we need to have a gap analysis of where we are. What are our present workflows? What are the PCMH workflows, right? Here, some practices use this workflow for NextGen, where this standard for is care management and support. Element A is care management and support, right? And then factor 1 is behavioral health conditions. And here, it says that, it says that auto credit. Auto credit, let me talk about that a little bit. Let me talk about auto credit. In the spreadsheet, they're saying auto credit because NextGen is pre-validated. That means that NCQA has allowed 42 factors within the PCMH program for EHR vendors to get auto credit on. So if you have this auto credit, and the vendors do not have to get all 42 factors, different vendors get a different amount, different number of factors. I think NextGen is around 33 factors that we have auto credit on. And what does that mean to our clients? That means that when it comes to addressing that factor with NCQA, our clients do not have to support any documentation or any reports because NextGen or the EHR vendor has already pre-validated. So when they look at auto credit, for example, NextGen does not have auto credit for this one, or this factor is not available for auto credit, and that's why I have a no there. However, NextGen also provides crystal reports, right? We have 57, 60 crystal reports, and so this spreadsheet will show you, yes, NextGen for this factor has a crystal report, right? The next thing is, do we need to use a report writer for any reason for any of these factors? Or do we need a documented process for this factor to submit to NCQA, right? Or do we need some kind of report or some kind of a log or some kind of example or some kind of a screenshot to submit to NCQA, right? What is our workflow to meet that factor, right? What parts of the EHR are we touching? So it's good to have a good gap analysis of your workflows, of your reports. Many times you'll find that you're already doing a lot of the things, and those points will come easily to you. And there's sometimes that, yes, you do have to look at a new workflow or a new report or a new screenshot, right, or change your workflow. And it all depends on how well you do your gap analysis. Now, we talked about how you should be involved with the PCMH program. We also talked about what the practice should be doing as far as creating a core team and a gap analysis, and there's other elements involved there. But also, we also need to talk about how the EHR vendor can support you. And I just mentioned the pre-validation point with the auto credit, right? Also, your vendor should be able to support you with reporting, meaning that do they have reports available that you can use, right, so that you don't have to create your own report, because that can become cumbersome. Sometimes you may not have the SQL expertise to be able to do that because you're a smaller practice, or you're a larger practice and you don't have those services. So you need a vendor that provides those reports so that you can submit them to NCQA. You also need subject matter experts in PCMH, like I stated, certified content experts that can kind of cut you through the process when you do have questions. They can come in and show you workflows, standardize your workflows, teach you PCMH workflows, teach you PCMH documentation and process, right? It would be helpful to look at your population and look at population health and see how your diabetes populations are doing, or your hypertensive populations, or whatever population that you want to pay attention to, that you have a way of creating reports, but not only a way of creating reports, but a way of reminding your patients of the services that are due for, and that functionality should be available within your EHR. You know, patient portal, that goes without question. It belongs in this PCMH paradigm, or this practice transformation paradigm. Practice management that is able to report on access to your patients, whether it's a same-day appointment or whether it's different types of clinical encounters, or different scheduling elements. Your practice management should be robust enough to create the reports for you. And you need to also have a care management suite, because you're identifying patients within your patient population that need deeper care than the general population. And how are you going to care manage them? What templates are you going to use to care manage them, right? And you're going to need technical expertise. A vendor should be able to provide you with technical expertise, where if you have a customized workflow, or a slightly customized KBM, or customized EHR, that your technical experts can assist you in providing the reports you need. So your relationship with your vendor becomes critical, because they will make your life easier as you go through this transformation process. Just to show you the pre-validation that I was talking about earlier for NextGen, you will notice that there are 17.87 points available for auto credit. And you will notice all the auto credit factors that we have auto credit for, all these, right? So whenever you see auto credit, that means that the practice does not have to submit any documentation or any reports to NCQA, because the vendor has already been pre-validated for those specific factors. So it's good to select factors that you already have auto credit, the vendor has auto credit for, so you can get some easy way to get points, right? There's also a thing called practice support right here. So you notice auto credit factors. There's another thing called practice support factors. All that means is, this does not mean that a client does not submit documentation or reports to NCQA. This means that the practice still does have to submit that information. However, it shows that NextGen has the functionality and the capability to be able to be compliant with that factor. That's all that means. It adds an extra bit of competence to you, but you still have to submit that documentation to NCQA. So that's the difference between auto credit and practice support in the pre-validation, right? All right. And also, your EHR vendor should have reports available to you. We have 60 reports available to assist you to getting up to level 3 recognition for PCMH. They come in 2 packages, but there are a total of 60 reports for different factors, and they're crystal reports. And not only do we have those crystal reports, to go along with those crystal reports, on our website, we have our white papers available that defines the workflows for those reports. So if you follow the workflows on the white papers, then your report will be accurate. And just to show you how those white papers look like, and it looks like this, and it just shows you step by step on with pictures on workflow, so that you'll be successful in your reporting. All right. And last but not least, your vendors, NextGen, has the patient-centered medical home certified content experts. They can come in and they can do web access with you. They can come in to on-site with you, and depending on where you are along the spectrum of practice transformation, and provide planning, provide gap analysis, workflow redesign, process redesign, policy and reporting, and create reports to help you get recognized. And your vendor should help you with that. Should help you with that process. And just to show you that for NextGen, there are 2,300 healthcare providers that have achieved PCMH recognition. So with that said, I have come to the end of the presentation, and myself and the panel are available for questions. And again, I thank you for learning with me. Thank you very much.
Thank you, Dr. Mattarella. That was just excellent. That was so comprehensive. I learned a lot more than I knew before this, so I really appreciate that. I'm looking in the Q&A panel. I don't see any questions. Oh, somebody has a question here. Let me see if I can find it. Let's see how we do this. Amanda, can you see his question?
Yeah, it's actually just a comment thanking us for all the information.
Oh, you're very welcome. We're happy to have you. Please come to more. Anybody else out there with a question for Dr. Mattarella or our team? Well, in any event, you all should have my email address. That's efriedman@nextgen.com from the invitation to the webinar. And just if something occurs to you that you would like to know more about, whether you're a client or not a client yet, please feel free to email me, and I'll ensure that the appropriate person gets your email. Okay, I think we're good. Okay, well, I'll stay on the line for a little while just in case somebody has some questions. Other than that, I thank you all for attending this afternoon. I know Mondays are tough days. You have a lot on your plate. We appreciate your spending an hour with us.